So today, like I said, mobility, fall risk assessment, and management. A very important M in the 4 M's. And why is it important? Falls are common, basically. The older you get, the more likely you are to experience a fall. And they're the most common events that threaten independence in older adults. So it's the thing that makes people move from independent living to assisted living, or from assisted living into nursing homes. 1 in 3 adults greater than the age of 65 report falling each year, and it's actually something that's often underreported or not reported for fear of losing independence. 50% of those greater than 80 years old have reported a fall in the last year. And so obviously that makes sense. The older we are, the more likely we are to have frailty and other chronic medical diseases that put us at risk for fall. And so the more likely we are to fall. And that holds true in studies. And then complications of falls lead to death from injury. And that's another reason it's very important. Right? The majority of falls result in some injury. If it's not a fracture, it can be subdural or intracranial hemorrhages. It can be large hematomas and bruising. There's a significant death rate attributed to falls, and that increases with age. And the highest mortality is noted in men aged greater than 85, with 180 deaths per 100,000 population falls. And I think one of the biggest things is also fear of falling, because we know that fear of falling causes isolation in the older adult, and the more isolated an older adult is, the more depression, cognitive decline, and dementia, and then increased risk for falls from not moving and having an expanded socialization. So if we're fall and we become fearful of falling again, then we kind of isolate ourselves down. We don't do the activities that we used to do, and then in turn we become more likely to fall. And so it's a vicious cycle. And so it's very important that we are always on the lookout and asking the question to our older adults: have you fallen in the last year, or had any near misses? And I think it's important that we start to do some evaluations in our clinics that give us an indication that somebody's at risk for falling, so that we can catch people before they fall, so that we can prevent the down flow of all the events that happen. So again, falls are associated with a decline in functional status, assisted living or nursing home placement, an increased use of medical services, and the fear of falling. And so cost is huge, and the downward flow of more falls and more isolation and more depression and more dementia and then more functional decline. It's just, like I said, a vicious cycle, and we need to intervene at some point so we can turn it around. There's also the risk of the person who falls and lies there, 24, 48 hours before somebody realizes that they haven't heard from them and goes and finds them. And then we deal with a more significant hospitalization that often results in rhabdomyolysis and kidney failure and so on. So the cost of falling is huge on our medical family. So increased emergency department visits, increased hospitalization, and increased cost to the healthcare system. So we take for granted walking. In our younger, agile selves, we don't think about it at all, but it is really a very complex process that involves many, many systems, right? So it involves the brain, especially the higher level brain functioning of motor planning and processing speed. It involves the vestibular system, so you're knowing where your head and body is in space. It requires input from vision and the other senses, so peripheral neuropathy and peripheral nervous function. It requires muscle strength, muscle flexibility. It requires the joints to be in line and strong. It requires you to have good functioning cardiovascular system as well as lung system. So all these things are working together to keep us up on our feet. And normally, if we have good vision and proprioception, we can see that if the ground is uneven, that we have to step up higher because there's a crack in the sidewalk. And if we hit it slightly with our toe, then we're able to quickly get the nerve relayed back to our brain that sends out a very fast motor planning to adjust that step and catch ourselves before we fall. And all those things slow as we get older. Our vision is not as good, our hearing is not as acute. We have weakened muscles and decreased proprioception, decreased muscle strength, and we're on multiple medications that can affect all of these things together. So really, walking is such a complex thing that we, like I said, we take for granted and we do it without thinking, but is a very complex process. So besides the intrinsic or things going on in our own bodies to help with our walking and staying on our feet, we have environmental or extrinsic factors that affect falling. And so the biggest one is medications. That's medications. Always look to medications because those are likely to be contributing to the risk for falling. Obviously, shoes. There never a day goes by in my geriatric clinic when a sweet older woman comes in who is unsteady on her feet at baseline, but wants to look good for the office visit, and so has, you know, a 1-inch heel. Or people who are declining in their flexibility want the slip-on shoes, and so they have the slip-on shoes that don't have a heel. And those become a problem because without a shoe that is covering your heel, you have to change the mechanics of your walking. You have to squeeze your toes, which then makes you have to have a higher step to clear those toes through your stride. So shoes are a big deal. Then the environment around you, you know, uneven sidewalk or uneven hill that you're walking down with a pothole or a little hole in the grass. In your home, do you have clutter? Do you have rugs? Do you have the threshold? Do you have poor lighting? What kind of bathtub do you have? Is that gonna cause you a problem for falling? All these things and many more that I haven't mentioned can contribute to falling. Even wind. Outside, I've had an older adult who fell over because of the wind here in Fargo one time. And then certainly ice here plays a huge role in our stability and for any age, but certainly becomes more of an issue the older we get. So all those environmental extrinsic factors are important to consider as well. And so on to medications, which deserves a whole talk in itself, but there's certainly many medications that have been attributed to falling in older adults. And it's the ones you think about, the anticholinergics, so the medications that cause blurred vision, dry mouth, constipation, can affect our balance and our stability. And those, you know, the biggest one I can think of that we run into all the time is Benadryl, right? Somebody takes a Tylenol PM that has diphenhydramine or Benadryl in it, and then they're falling. Any other kind of first generation antihistamines. Simple hypoglycemic. So insulin is the #1 cause of older adult in the emergency department as far as medications go. So are we driving down there? We're trying to control their blood sugars too well? Are they getting hypoglycemic and then falling down? Is it that we're over-treating their blood pressure or their congestive heart failure? You know, our algorithms for heart failure have us ramping up ACE inhibitors and diuretics and beta blockers. And so as we do that, are we causing orthostasis so that they have no blood pressure when they stand up, and that's contributing to falling? Antipsychotics are big ones, and we seem to be prescribing these more and more when we really should be limiting them in our older adult. I've seen, for example, Seroquel or quetiapine used for sleep in the hospital so much, and then the patient gets discharged on a small dose for sleep, and we forget to take it off, and those people are more likely to fall. Even SSRIs have been shown to increase your risk for falling the older we get. Certainly other things that are sedatives like muscle relaxants, some of the medications for the prostate can contribute to fall, the alpha blocking agents, benzodiazepines, so the lorazepam, Ativan, Xanax, those kinds of medications, certainly very, very high risk for falling in our older adult. So medications are huge, even ones that you don't think of as being dangerous or on the Beers list criteria for inappropriate drugs for older adults can become dangerous, especially if they're causing low blood sugars or low blood pressures or low pulses, right? So we got to watch out for those things. Especially if somebody reports, you know, when you find out in their history that they had recent adjustments in medications changes, you've got to ask about what are they taking over the counter, because they feel like those medications are not dangerous, but they certainly can be some of the most dangerous things we've taken. Like I said, Benadryl is one of those. And in studies, it's even been shown that it doesn't matter what medication or one particular medication, but certainly the total number of medications increases your risk for falling. So even if you're on medications that are thought to be very safe in the older adult, the more that you have to take each day can increase your risk for falling. So really got to do a good review of medications in somebody who presents to you with falls, because it's most likely something there is contributing. So how do we evaluate somebody? You know, I'm a medical director of a balance and stability clinic, and it's a multidisciplinary clinic where we have the physician or advanced practice provider, the physical therapist, the social worker, the pharmacist, all working together to come up with a plan to improve and decrease, improve balance and stability and decrease falls. And so what do we do in that clinic? But my job, you know, we're lucky enough to have the pharmacist to help review the medicines, but to get the history. So important to have them tell you about their most recent falls. What happened? Tell me what happened in your most recent fall. Were you dizzy, lightheaded? Did you have palpitations or racing heart? Did you have shortness of breath or chest pain? Were you shaky or jittery? Did you just stand up, or had you been standing for a long time? Do you remember tripping? Do you remember the whole thing, or did you lose consciousness? Was it actually a syncopal episode? And I think on examination of somebody who comes in with a fall, you have to check vision, whether it's a Snellen card or you're doing the E across the room. You have to check out their vision. You have to ask about cataracts or other problems with their vision. Even ask about if they have nice smooth glasses. Do they have bifocals or trifocals? Because that can certainly become an issue as we get older. The brain is just not fast enough to switch between where you're looking and your processing of what you're seeing. You've got to check orthostatic blood pressures. And then I think it's important to have some other test of balance. So whether it's quick and in your office, just the act of standing from their chair. Can they stand up from their chair without using their arms to push off? That tells you something. You know, there's certainly lots of studies and evaluation done on the TUG, the timed up and go. The physical therapists do a huge battery, which it can be the Berg balance, which gives you a nice score for fall risk. You can simply do the progressive Romberg. So standing, eyes open with your feet together, and then your eyes closed, feet together, and then semi-tandem, so one foot slightly in front of the other, eyes open and eyes closed, and then full tandem, eyes open and eyes closed. That's a progressive Romberg. Can they fall, or do they have to step out? And that's a score out of 6. So if they can complete all those, maintain their balance without stepping out with eyes open and eyes closed, that's a score of 6 out of 6. And then you take away the things that they can't do shorter than that, right? You got to assess, you've got to assess their strength, their vibration sense, their fine sensation in their feet. Do they have a tremor, a resting pill rolling tremor? Do they have Parkinson's disease? Are you evaluating here? Are they more rigid? Do they have bradykinesia? All things that need to be evaluated. Do they have swelling in their legs? Do they have, you got to look at their history, right? Not only the history of their fall, but their past medical history. Do they have diabetes? Do they have, so they're more likely to have peripheral neuropathy. Do they have joint issues with hip and leg, knee pain and osteoarthritis or low back pain and other things that are causing them? And evaluate their gait. Do they have a wide base gait? Do they have an antalgic gait where they're limping? Do they have laxity in their joints? Do they have the shuffling gait and don't have a good, nice, high step? All those things you can evaluate along with a physical therapist or on your own to get an idea of what's going on. And then the typical Parkinson's, do they have flat affect? Do they have hunched posture, short shuffling gait with the fenestrated turns and lack of arm swing? Those are all things to be aware of as you're evaluating somebody who's coming in for falls. We look at lab tests, and I certainly make sure that in the last 6 months they've had a blood count, CBC. Do they have an infection that we're not aware of? Do they have elevated white count? Do they have anemia that's contributing to dizziness and orthostasis and fatigue? Do they have hyponatremia or chronic kidney disease? Do they have good potassium levels? What's their thyroid level doing? That can be one of the first signs of hypo or hyperthyroidism. Vitamin D deficiency is certainly essential to treat a deficiency. And then so often we get B12 deficiency affecting our peripheral neuropathy, our strength and our movement. And, on our labs, I think a normal B12 goes down to 200, but I always treat a B12 level less than 400. And that's because in the past I used to check in the methylmalonic acid. If it's high, then B12 is low. And so I used to always do that, but it seemed to be less than 400. I was always treating. And then imaging, rarely do I get x-rays or MRIs, sometimes of the brain or the spine if I think that there's, spinal stenosis or other things that maybe warrant such a thing, but very rarely do we need something like that. I do make sure that they have an up-to-date DEXA scan because it's important in these people that we're treating and preventing fractures. And so I treat, osteopenia with a high frac score or osteoporosis, certainly make sure that we're on treatment for that. And then so important, in our Balance and Stability Clinic, I am trying to get our dietitians and nutritionists to join us because I think that's a piece that we're missing that is so important. You have to ask about their diet because so often in our older adults, it is the tea and toast. They aren't putting in the effort to make a full, well-balanced meal, or because of swallowing or chewing difficulty with dentures and teeth, they're not doing meats anymore, and then they aren't aware of other ways to get their protein necessarily. And so having lots of discussions about the protein and how our seniors are not getting enough. They actually require much more than a younger adult to maintain their fat-free muscle mass. So, a 20-year-old needs 1 gram per kilogram of protein to maintain their muscle mass, and an older adult needs 1.5 grams per kilogram. That's to maintain their current muscle mass. If they are needing to build it, then they need that much more, and that's a lot of protein. And so finding ways to help your patients get that extra protein in their diet is essential. And then the SARC-F, I think I show it to you here, is a way to assess muscle weakness, right? That's muscle atrophy. Sarcopenia is the term for that. And it's important to know the term sarcopenia because often if you're trying to get home health and PT and OT into the home for home health care, Medicare will not accept weakness as a diagnosis to cover, but they will accept sarcopenia, which is just a fancy word that basically means the same thing. And so here's the St. Louis University SARC-F screening for sarcopenia, which is loss of muscle mass, right? It's weakness, loss of muscle mass. And so these are typical questions to kind of assess that. And I think, you know, you can get a gist of this just in evaluating the patient, but this is another way to help determine, do they have loss of muscle that's contributing to their balance and their stability and their increased risk for falls. So how much difficulty do you have in lifting and carrying 10 pounds? How much difficulty do you have walking across a room? How much difficulty do you have transferring from a bed or a chair? How much difficulty do you have climbing a flight of 10 stairs? And how many times have you fallen in the last year? That score, and you can say a total score of 4 or more indicates sarcopenia. Like I said, that can be a Medicare covering diagnosis for home health. Then we talked about the different ways to, you know, in our clinic, not my balance and stability clinic, but just general primary care clinic, we're trying to catch people before they fall. So who's at risk for falling, even though they haven't fallen yet? How can we catch them early enough that we can intervene and prevent them from becoming fallers? And so there's several ways to do that, but the one that we're evaluating right now in our clinic is gait speed. And so this has been a well-studied kind of evaluation of balance and fall risk, and the ability to do activities of daily living and to require a higher level of care has been kind of teased out with various studies. So what is gait speed? It's timing them walking, you know, you're timing them for the 5 meters and then assessing meters per second, how fast can they go. And so I think I have a little video here, I'll get going. And basically, as you can see on the wall back here, we have a starting mark, and then the green is the go where we start the timing. And then here we'll have another green arrow that's just out of the picture here, where they stop timing, and then a deceleration phase. So you allow kind of an acceleration and deceleration, but you time in the middle. And then you do at least 2 of these trials and time them and take the average. But here is an example of us doing that. Those are our markers that we've pre-taped in all our hallways. And we do this once a year. Like I said, trying to catch somebody, or if there was a huge change in their health, we would do that as well. See, she started it at the green, and our rooming nurse is going to stop it at the next green. And then she'll have her come back and do it again to get the second timing at the green marks. And so, as you can see here, kind of a good cutoff is 1 meter per second. If someone's walking speed on average is 1 meter per second or faster, then they are less likely to be falling, less likely to be hospitalized, or more likely to be independent in their activities of daily living. They can actually do lots of household activities. They're independent in their self-care. So if somebody is greater than 1 meter per second, we say, you're doing great, continue your regular maintenance exercising. If someone's coming into the clinic and they're 0.8 meters per second to 1 meter per second, then I'm prescribing them an exercise program. And right now what I'm doing is giving the National Institute for Health on Aging has really good packets and videos. And so I'm giving out that information. You can get the packets for free if you go to the NIH website and have them mailed to you and then hand them out. And they have several different pamphlets and, like I said, videos on exercising. And so we hand those out and say, you got to start an exercise program, or we send them to any of, kind of right now in COVID we aren't, but otherwise you would be sending them for, you know, Silver Sneakers or some sort of Bone Builder, some sort of program like that. If they're 0.6 to 0.8, I'm sending them for official physical therapy for balance and strengthening training. And if they're less than 0.6, then we're generating a referral to the Balance and Stability Clinic to see if there's anything else we can do where we all work together. And as you can see here, you know, the slower you get, the more likely you are to be dependent, to fall, to have to be go to a hospital or to a nursing home after hospitalization, mortality. So very interesting work has been done with walking and gait speed. And so we're trying to use that as a way to intervene before somebody falls. Other ways you could do it that are validated out there, the timed up and go test. which is a similar thing. You're having somebody sit in the chair, stand up, walk 10 feet, turn around and go sit back down, and you're timing them. And then if an older adult who takes greater than 12 seconds to complete the tug is at risk for falling, and you can find more information for this at the CDC, and there's a study program. So those are just a few. You can do stand up, sit down, or like I said, just simply have them stand up from their chair. If they can't stand up on the first try without the use of their arms, then they're at risk for falling. So what do we do if somebody is falling? How do we, and we've evaluated them, what can we do? Certainly multiple studies. You can prescribe exercise and you get results if you can engage these people and get them to do it. Exercise is important. Exercise has been studied, validated, and proven. You particularly need balance and strength training as well as gait training. Flexibility is important too. So, high intensity interval training is important. Strength training, there's kind of a dual task training where you are walking and talking or having to count backwards. That's important because that's kind of multitasking, and getting your brain to do multiple things at once helps with processing speed. There's balance perturbation where physical therapists do that, where they kind of instigate almost a fall and see how you catch yourself and help teach you and train you to catch yourself. All those things are validated and proven, and we should be doing. We need to definitely take a look at their medication lists and discontinue, minimize those medications that we know are dangerous and likely to be causing them trouble. We need to de-escalate medications that are causing, low blood sugars or hypotension. And we need to try to deprescribe so that we're on only the important medications that we need to be on. So we need to get rid of unnecessary medications and avoid prescribing cascades. So manage postural hypotension. If medications aren't contributing, then what can we do? Last case scenario, they need midodrine, but can you increase the salt intake in the morning, increase their fluids, because most likely they're dehydrated, right, contributing. So hydration, and I always say, you fill up a bottle, you sit it at your favorite chair, and it has to be done by 3 in the afternoon. And you have to have kind of sticky notes all over to tell you to drink. You got to manage foot problems. You got to talk to them about their footwear. They don't need to be wearing high heel shoes. It should be tied or cover the heel. If it's a slip-on, it has to cover the heel. Velcro is okay, but nice, secure, stable shoes, tennis shoes. Supplement their vitamin D if they're not, or if they're low or deficient. Treat vision impairment. Get that cataract surgery if you need it. Change from trifocals or bifocals to monocular glasses when you're up and about, and have the readers for when you're sitting down, because our brain just kind of loses the ability to make that change fast enough and can contribute to falls. Manage heart rate and rhythm abnormalities. If you're going into AFib with RVR and that's what's causing it, treat that. And modify your home environment. We're lucky with the Balance and Stability Clinic. We work with our OTs who go into the home and do safety evaluations and talk about clutter and rugs and lighting and night lights and handlebars and all those good things. Not using step stools, but using grabbers, extension grabbers, all those good things to help keep us safe in our home.